Yeah, for folks who just came in, I have tons of leftover candy from last night, so please help yourselves. Oops, hang on. Today it came with me, tomorrow to go to work with my husband. Alrighty, so it's 1. We'll get started in just a minute. I'm gonna take a sec to just check everybody off that's here in person and on Zoom. And just to orient us as we get started today, we're gonna be talking about psychiatric disorders and how they overlap with neuropsychological issues. So that is a fun but sometimes depressing topic as well. So, woohoo! I mean, not that anything we talk about in here is necessarily not depressing. So, it's the nature of the clinical classes, right? Like they're very interesting, but also you could just be like, "Oh, I feel like Debbie Downer today." Womp womp. Alrighty. All right, and just a reminder to groups to make sure you're meeting with me. I've met with 2 groups already, and in addition to me giving you guidance about them, you also get to pick which day you present when you meet with me. So, okay. Thanks for letting me know that. That's helpful. We got a couple people together today. Love that. Okay, sweet. Okay, and I know that it isn't the easiest to read today. Someone put a very nice happy Halloween up, but then didn't actually like erase it well. So it's a little on the videos today, and I know that. So we know that the mind and the body are related, right? And this is not only obvious in neuropsych, but also in health psychology, right? And just in the interaction of physical and mental symptoms. Most psychiatric or behavioral disorders do have some sort of biological, anatomical, or genetic basis. Slowly but surely, we're getting enough research to show that, right? But some of that we've known about forever. So like Hippocrates, the Hippocratic Oath guy, right? He knew that depression ran in families. So he didn't call it genetics, right? But it was genetics. So some of this we've known about for quite some time. And so that leads us to, knowing these interactions, knowing that they can be helpful, they can be not helpful, and keeping that in mind as we go through things. And so your book kind of focuses in on a few disorders: schizophrenia, depression, and mood disorders, and also some of the anxiety related disorders as well. And one of the things I wanted to focus on, just because of the implications for the brain, is psychosurgery. So we're going to start there, and then we'll kind of backtrack to talk about some of the disorders more specifically. And so we still do psychosurgery today. It's just often much more targeted, right? We'll purposely create lesions, or as we saw with our case study on Monday, sometimes they'll take out whole hemispheres of the brain, right? If they need to for epilepsy or other reasons. Psychosurgery's definition is destruction of a region in the brain to alleviate psychiatric symptoms. And neurosurgery, which is what we tend to think of more today, right, is brain surgery intended to repair damage or alleviate symptoms. And so this has a long history in prehistoric times, and really longer than we probably like to admit. One of the things people did to try to alleviate mental illness was called trephination. And this is where you would drill a little hole in a person's skull, because the idea is it would let the evil spirits or the devils or just sort of whatever phrasing you wanted to use out. And they did this, in the era of no antibiotics, right? Things along those lines. So it didn't always go great. But we tried to get more and more sophisticated. And one of the things that happened as we get more sophisticated is we can have some stumbles along the way. And so this next clip is about lobotomies. And just for people who are squeamish, they will show some stuff and talk about stuff in pretty graphic detail. So just heads up. And this was a larger PBS documentary. I don't show the whole thing just because this is usually the end of the semester when we're kind of steaming through things. But if you're interested, I'm sure you could probably track the whole thing down somewhere online.
He was an idealistic doctor, hungry for fame, who would champion one of the century's most infamous medical procedures.
He wanted to solve the problems of psychiatry, and he wanted to do it fast.
The lesson here is not how a man can go off the rails, but is how
Turn it up a smidge here.
science can go off the rails.
Ellen Ionesco was the first patient to undergo a procedure Dr. Freeman had perfected only weeks before. He called it transorbital lobotomy.
In a transorbital lobotomy, Freeman would first have the patient rendered unconscious through the use of the electroconvulsive shock machine.
Just before he threw the switch, we all had a laying on of hands and we went for a little ride.
Usually 3 successive convulsions are necessary, but in old people a single one may be sufficient, while in a sturdy young person 4 or even 6 convulsions may be administered without danger.
The patient would then enter unconsciousness for a relatively brief period, but several minutes.
Now that the convulsion has subsided, the nurse holds a towel over the nose and mouth of the patient.
Freeman would peel back each eyelid, insert his ice pick, and with a hammer, tap through the brain, wiggle it about, sever the frontal lobes, withdraw it. And when the patient came to, he or she would be given dark glasses to hide the black eyes they'd been given.
We didn't have a refrigerator, we had an ice box. The first ice picks came right out of our kitchen drawer, and they worked like a charm.
The guy who was just talking is his son, so this is a first-hand account.
Turning now to the operation itself, very little preparation is necessary for transorbital lobotomy.
The instrument was put in above the eyeball and in the plane of the nose. You could feel it hit the roof of the orbit, and then with a tap of a hammer you could knock it through. The whole thing would take 3 or 4 minutes.
This patient came to the hospital this morning after breakfast, and he will leave tomorrow afternoon.
There are reports which he proudly writes down in his diary about fellow professionals fainting as he proceeds in this, or vomiting.
Dr. Watts didn't say anything. He simply turned around and walked out.
Spurred on by Freeman, the number of lobotomies performed annually soared from 150 in 1945 to over 5,000 in 1949. Despite the known side effects, there seemed to be an endless supply of willing patients. Ultimately, the fate of lobotomy would be settled by a pill. In 1954, a new drug called Thorazine began to sweep through state mental hospitals.
Thorazine was initially marketed as a chemical lobotomy. I mean, this was seen as a selling point, that it produced results similar to lobotomy, but without, of course, all the risks of the surgery.
Freeman decided to move to Los Altos, California, to resurrect his career. Far from the reproachful Eastern medical establishment, he could try to bring lobotomy to new categories of patients.
If housewives found their early 1950s existence too depressing for words, why, Freeman had a solution that would get them through their day happy as little clams. If children were misbehaving, conditions we might now see being called hyperactivity disorder, why they might need a lobotomy.
In all, Freeman lobotomized 19 children under the age of 18, including a 4-year-old. By 1967, Dr. Freeman had personally performed more than 2,900 lobotomies. In February, at Herrick Memorial Hospital in Berkeley, he performed his last when a patient died of a brain hemorrhage. Freeman was stripped of his hospital privileges and soon retired from his medical practice.
All right. So based on what we know and what we've talked about from the frontal lobes, what would happen if you stuck an ice pick in someone's frontal lobe and wiggled it around? What sort of functions would you damage? Yeah. Yeah, for sure, right? Exactly, yeah. So like their ability to organize, to kind of care about organizing, right? Their personality, their distress, right? And so what lobotomy did was essentially turn off the caring about what was happening to you. And so, yeah, it made these people easier to be around, but it didn't make them more whole or functioning people, right? This next one has an MRI examination of someone who had been lobotomized. So I think that that's something kind of interesting to look at here.
Was this an ice pick? It's the sort of thing you'd have found in every 1940s home. It was absolutely perfect for what he needed it for. It was hard, it was tough.
So this is the like OG refrigerator slash freezer, was you would get these chunks of ice, like from someone like Kristoff and Frozen, right? There would be people who sold these and stored them in places where they wouldn't melt in the summer. And then when you needed something, you would have to like chop off a chunk to ice your drink. So
Tough, it did the job. So what Freeman did is he would anesthetize the patient using ECT. Then he would get his ice pick.
and like that is mind-boggling to me too, that like they thought that was enough anesthesia, was just like, let's shock them with ECT, electroconvulsive therapy, to where they're non-responsive, and then we'll stick something through their eyeball, right? Like not through their eyeball, but you guys know what I mean. Like they didn't even like put them under general anesthesia. It's a little mind-boggling.
And a hammer, and he would go into the brain through here. I think I'll try it on a skull rather than myself. Here it is. Watch closely. He's going in here. He pushes the eyeball out of the way and he works his way to the back, to a thin bit of bone right at the back.
Again, sorry, squeamish people.
What you do is you bop it through the skull. Yep, going through, going about 5 centimeters, and then you just squiggle it around. He was actually much more adept than I was, but he would use 2 at the same time. And then out it comes. And according to Freeman, the only post-operative care the patient needed was a pair of dark glasses. Transorbital lobotomy was so simple, it could be done by anyone, anywhere, and in under 10 minutes. Walter Freeman performed thousands of lobotomies. His technique spread so widely, it's estimated that more than 100,000 people were lobotomized, with mixed results.
They had their failures, but there again, a remarkable number of those patients returned to their families and had some kind of a life.
Now, it's certainly true that some of the patients became more docile and easier to handle, but many of the others were so badly damaged they could never take their place in the world. And of course, some died. This young man is one of lobotomy's success stories. Cases like his encouraged Freeman to extend his practice. He moved from using lobotomies as a last resort to using them on people who, by anyone's standards, were perfectly normal. Hi there. Howard, I would guess?
Hi, I'm Howard Dully.
Hello, I'm Michael Mosley.
Glad to meet you.
And you. So this is your sort of childhood neighborhood, is it?
Yes, it is. This is the place.
Which way's the house?
House is over in here.
What were you like as a child?
Well, I wasn't an angel. I was very rambunctious. I liked to roam the streets a lot and liked to be alone. I found out if I was alone, I didn't get in trouble.
Yeah.
Because no one was there to get me in trouble. And I just wanted to be left alone, pretty much, you know.
Howard's mother died when he was just 5 years old. His father married again, but Howard and his new stepmother, Lou, had a very difficult relationship.
I felt that she was trying to take the place of my mother, and I resented that, so.
How did she respond?
She would punish me or do things to me that would aggravate me, so it would just snowball. Once she did something to me, I'd do something back, and pretty soon it just got out of hand.
Their relationship got worse and worse, to the extent that Lou took Howard to see Dr. Freeman. It was just before his 12th birthday. Do you think she had any appreciation of what a lobotomy would do?
I don't know that she cared. I think that she just wanted a solution to me, and whatever that solution brought, she was willing to accept.
This picture shows Howard undergoing his lobotomy.
I wasn't changed that much, and I still had my faculties and things. I thought she was going to get more of a docile, robotic type kid that she could control.
If the lobotomy was supposed to pacify Howard, it failed. He became increasingly disruptive. Unable to manage him, his parents sent him away from home forever.
I had gone to several people's homes and then made a ward of a court at juvenile hall. And since I didn't commit a crime, they sent me to Agnews at age 13, 14 years old. And I was put in with adult mentally ill patients.
Wow.
I just was a kid that had no place to go, is what they kept telling me. We have no place to send you. And then I went back to juvenile hall, back on the streets, got in trouble because I didn't have any skills or know how to live. And went back to Agnews till I was 20. It was either that or prison.
Do you think Walter Freeman stole something from you?
I think he took my childhood. I think he took my childhood and some of my adulthood, because I'm probably about 20 years or better behind the average person.
What I'd really like to do is I'd like to take you along to an MRI machine where we can actually have a look inside your brain, because I think it is extraordinary. I think you're an extraordinary individual, and I'd be very, very interested, and I hope you are, in what the MRI machine might reveal.
Well, thank you.
Of the 100,000 people who were lobotomized, Howard is the first to have a high-resolution MRI scan. I feel privileged to be here. I've seen into parts of you that no one else has ever seen into. Right, take a seat over here. Take a foot. So we have had a good look at your brain. It's been absolutely fascinating.
Here's the front of his head. This is his eyebrow, his eye. His nose will be over here, the back of his head. The knife should have gone in above the eye.
Right, okay.
And then you can see this black region here is not normal.
That's abnormal, is it?
That is abnormal, yes.
Right.
See, inside my head, I have a black hole. There you go. I got two of them, as a matter of fact.
This way
So this would be
instead of from the side.
These huge black cavities were created by Dr. Freeman's instruments.
Black hole is the same as this from a
And
different
on both
view.
sides?
Both sides.
Right. So what would that area normally be doing?
So the frontal lobes are important for long-term planning, inhibition of a response. One of the most obvious things that people who have damage in this part of the brain is they become very impulsive.
Right, okay.
And unable to control their impulses.
And that's the paradox, isn't it? They went through all that, they put you through all that, and actually it was the exact opposite of what they were hoping to achieve.
Right.
It would have made you worse in a funny way. It would have made you much more likely to misbehave. Is that right?
Yeah, I would agree. Certainly if you did this to an adult, I would expect them to be permanently impaired and
Right.
not be able to control their impulses.
Ironically, it was probably Howard's youth that in the end prevented him from going completely off the rails. His young brain was able to rebuild pathways responsible for impulse control and which govern reasonable behavior. The tragedy is that when Howard was operated on in 1960, safer and more effective psychiatric treatments were widely available. Nonetheless, Freeman went on performing lobotomies for many more years, only stopping when he was 72.
So you could see just giant damaged areas, right, in the frontal lobes, which is horrific. And we don't do today, right? Today, if they do psychosurgery, it is a last resort. They make very small lesions in most cases. And they fully recognize it's not going to make abnormal activity suddenly normal, right? It's just going to probably control something that is making their quality of life not great. And so, like I said, now we'll sort of backtrack and talk a little bit more about the various disorders and how they impact the brain. We know just from what we've been talking about all semester that pretty much anything we're going to talk about is going to be linked to some sort of neurotransmitter issue, and that's certainly the case for the vast majority of these disorders. And so if we look at things like schizophrenia, right? So in schizophrenia, you've got delusions. Delusions are fixed false beliefs, and they can range from anything from thinking you are Napoleon Bonaparte to just believing that you're being followed, right? They can be very diverse. Hallucinations are hearing things, seeing things, tasting things, touching things, smelling things that are not there. So they're sensory. You often have disorganized speech and disorganized behavior as well. And then what are often called the negative symptoms of schizophrenia can sometimes be even more crippling than the hallucinations, for example. And these are essentially extreme depression. Your emotions are really blunted, you lose interest, you lose drive. So these are just some of the structural abnormalities for folks with schizophrenia. So their brains tend to be less, they have less mass, less weight. Their ventricles, those fluid-filled parts of the brain, are often enlarged. There are not as many neurons in the prefrontal cortex. So it's almost in some ways like they've had a little bit of a lobotomy. And they have some abnormal cellular structures in not only the prefrontal cortex, but the hippocampus. And so they struggle with things like the card sort. And so this is actually like what their neurons can look like. Instead of being sort of lined up and interconnected with each other, they're very disorganized, which again can mirror their speech and behavior. We know that there are various neurotransmitters implicated here. Dopamine is one, GABA is another one. Antipsychotic medication tends to act on dopamine itself. So that becomes important. Lots of different biochemical changes. So they think that they don't have the metabolites. Well, they don't even think, they know from research, they don't have as many metabolites that break down dopamine in the cerebrospinal fluid. Some of the receptors for dopamine are out of whack. Same thing with glutamate. And there's decreased mRNA for the synthesis of GABA. GABA is an inhibitory neurotransmitter. So when a neuron sends GABA across, it basically tells the next neuron, don't fire. And so when your GABA is less than it should be, it can mean excessive energy firing in the brain, which is going to lead to some of these issues. So schizophrenia tends to develop in late adolescence, although certainly it can happen sooner, and it can happen later. Not always, but oftentimes we describe this as a psychotic break. So some of you that took 256 with me last spring have heard this story, but I had a client who was in her early 40s, well established, working as an art teacher, in her own apartment, all that good stuff. And she was dating a guy that it was unclear whether or not he was actually involved with the Russian mob. He was at least Russian. And her psychotic break happened when she was at work, and she believed there were helicopters circling her high school, full of people from the Russian mob who were coming to get her. There were no helicopters. And after this psychotic break, honestly, largely due to the treatments for schizophrenia, which can really cause a lot of changes in terms of, yes, they stop the hallucinations and the delusions, right? But they can also just slow you down. They can cause weight gain. For her, that caused 80 pounds of weight gain. And she's someone who had an eating disorder as a young woman. And so that's why she came to me, is because that was part of what she was struggling with. And so she actually didn't have her job anymore, didn't even feel like painting, and she was an artist, and was living at home with her parents. So she was a little older than I am now, and I cannot imagine having to live with my parents. Like, I love my parents, but the thought of that makes my skin crawl, right? I just really like my independence. And so it was a really tough situation for her, and that just sort of amplified her negative symptoms, right? I remember one time when I was like working with my supervisor about her, I'm like, oh, I just feel like I'm not helping her. And he was like, this is a really hard case. And I was like, oh, I guess you're right. Like, you know, in my mind, I think I'd sort of made her a depression case, which, like, depression can be really hard cases too. But just like there were so many factors that we needed to take into account as well. It seems like there's not one single gene that causes this. And in fact, I want to say maybe 10 years ago, a study came out that suggested it's a combo of genes to such an extent that what we put under the umbrella of schizophrenia might actually be 6 distinct genetic disorders. But we still sort of group them there. In terms of how they do on neuropsychological assessments, they don't do great on long-term memory, whether it's verbal or nonverbal. So whether they're trying to remember figures or trying to remember words, they still struggle. And they have poor frontal lobe functioning. And depending on their level of functioning and symptom interference, they may not perform well on any test And I have a video that I really like that I want to show that illustrates why that is. So this is Anderson Cooper from CNN doing a schizophrenia simulator of someone who hears voices. And you'll see him trying to do tasks and how much of a struggle it is. One of these days, I'll get it open. There we go.
And then I switched to Liberty Mutual and saved hundreds. I know, exactly.
Hey, hon. It's nasty out there.
So I'm going to put these earphones in, and they're going to try to do a series of tests. Okay, so I'm now hearing sort of whispers and voices in my head, and the first test is on some number puzzles.
Listen, you suck and they know it. Can't you get this right?
Okay, so I did this test for 3 minutes, and I did not get a single one. It's very hard to concentrate when, if it's like music or something constant, it's easy, but people talking to you is very difficult. So now,
and I just want to stop real quick and point out for those of you who aren't as familiar with Anderson, he's a very intelligent person, right? He is someone who's known for being really articulate and sharp-minded. And so for someone like that to struggle shows that like your level of intelligence does not matter when you're experiencing this.
I'm going to be asked a series of questions by our producer, Susan, and these are basically a series of questions that a person would be asked if they were being admitted to a hospital.
Can you tell me what day it is?
Yeah, it's Sunday, June, I don't know, what's the date, 7th?
So I'm going to say 5 numbers, and I want you to repeat them back to me after I'm done.
So what she's doing right now is a mental status exam, a formal mental status exam to see if they're able to do basic cognitive tests. But as you can see, it's much harder for him.
Okay.
5, 23, 67, 2, 76.
5, 23, 67, something 76.
I'm going to say 5 words. You don't have to repeat them, but just listen to them. Cat, book, cigar, damage, and rain.
Make you okay.
Can you name the last 4 presidents of the United States?
Okay for you to be
Barack
here.
Obama, George
Come
Bush,
here. Right here.
Bill
Me.
Clinton, and George Bush.
Hear it? Hear
So
it
those
now?
5 words I said before, can you remember any of them?
Here. Hear it.
No. It's hard when, because sometimes voices are like whispering, and sometimes they're aggressive, and sometimes they're kind of comforting. And
Hear the tree.
but again, with people kind of talking to you all the time,
It's okay.
it's hard.
Don't worry. Now or later.
So I'm
Don't
going to try to
worry.
make a boat
You
out of
all right?
origami following these instructions.
Hey, it'll be okay. Near. Get near.
Shut up!
I want to talk back to the voices now, but it's really distracting. It's,
Do not do it. Do not touch that stuff. Eyes down. You suck! What are you looking at? This is easy. You want to touch that?
I can't do this.
Hand down. Keep your eyes down. Just do it, Stuart. Just do it. Do it. Filthy mind. Leave it alone.
It's also frustrating because they're telling me I can't do it, and so I didn't do a very good job with the boat. But it's really hard to focus when kind of people are whispering to you and talking to you.
Just come clear. Come near to me. Come near for help.
Hey, do you have yesterday's paper? Yesterday's New York Times? No? Okay, I'll just get today's. It's incredibly distracting on the street to have somebody talking in your head, and it makes you feel completely isolated from everyone else around you, and you don't want to engage in conversation with other people. You kind of find yourself wanting to engage in conversation with the voice in your head, because they're constantly being really negative and talking to you, and everything they're saying relates to things that you're actually doing. They're criticizing things you're doing. It's like it's like you have a chorus watching you and commenting on what you're doing, and you can't help it. I mean, I literally find myself wanting to kind of respond to them, kind of tell them to be quiet, and it's incredibly unpleasant. This is a very, very unpleasant experiment. It's really, I mean, it's eye-opening because it kind of really shows you what other people must be going through who deal with this on a regular basis. But also, like, I cannot wait to take these headphones off because it's really depressing. It's very negative. It makes you feel very, very negative.
So we'll stop it there, but you can see again, I don't think he did this for very long, maybe a couple hours max. And in that amount of time, he was already starting to experience some of the negative symptoms of schizophrenia, right? Those depression-like feelings. He wanted to talk back. I mean, we see people do this all the time, right? Folks who were walking down the street talking to themselves. When they first came out, I hated the little like Bluetooth things because I was working retail, and one of our like jobs in retail, we were told to like smile and say hi to everybody. And there would be people that appeared to be just talking to themselves, but they actually had the little Bluetooth thing, right? But like we've all seen people who are like walking down the street talking to themselves, and you can understand why based on what he's saying, right? Like you want to answer it. So schizophrenia obviously has very clear consequences, but it's not as common as some things. I think it's like 1 to 3% of people worldwide will experience schizophrenia, whereas for mood disorders, it's anywhere between 12 and 25%. And in particular, women experience closer to that 25% range. And so with mood disorders, we can see depression. So feeling depressed or down most of the day, nearly every day, feeling worthless, feeling guilty, not enjoying things you typically enjoy, finding it harder to move or speak, everything slower. Your sleeping and eating is disrupted. You have feelings of maybe wanting to end your own life, and your ability to think and concentrate is diminished. In mania or a manic episode, you experience excessive euphoria or feeling expansive or irritable. You have a really grandiose sense of self-esteem. You're overly talkative. You feel like you don't need to sleep as much. You have increased activity and agitation. And you're more likely, it's like, you lose your self-filter. You're more likely to engage in higher risk activities. So with bipolar disorder, you'll have periods of both depression and mania. There are different types of manic episodes you can experience. If you ever have what's considered a full manic episode, then you are diagnosed with bipolar 1 disorder. If you've only ever had what are considered hypomanic episodes, not as severe episodes, then you are diagnosed with bipolar 2 disorder. Now, in terms of what goes on neurochemically in the mood disorders, we know monoamines are affected, and in fact, MAOIs, or monoamine inhibitors, were some of the first generation of antidepressant medications that targeted these. We also know there's something called brain-derived neurotrophic factors, or BDNF. These are downregulated by SMEF. I don't even know what that is. By stress, and may affect functioning of those monoamine synapses. In both depression and anxiety, what has been implicated the most and what research has really focused on over, I would say, the past 30 years, biologically in mood and in anxiety disorders, is the HPA axis, the hypothalamic adrenal axis, or adrenal system. So what happens here is that the body will over-secrete cortisol. The body will always think it needs to kind of be in like a fight or flight mode. Cortisol is linked to chronic stress. We know that chronic stress not only has mental consequences, but physical consequences as well. Then this has a widespread influence on your general cerebral functioning, and it kills granule cells in your hippocampus, which of course in turn can affect your memory. And so this is that HPA axis over here. So hypothalamic, and then there's the pituitary and the adrenal gland in the kidney. And so basically, like, your kidney is supposed to activate this feedback loop that tells it, hey, we don't have to be stressed anymore. And in depression and in anxiety, this doesn't work the way it's supposed to. And that means that people experience stress more, which again is going to result in those various mental but also physical issues that are linked to chronic stress. So one of the sort of like miracle medications, I believe this one is on the Walmart and other drugstore $10 list, which means you can get it for $10 without insurance, is fluoxetine. This is an SSRI, which means it's a selective serotonin reuptake inhibitor. We know that serotonin is implicated in depression. It seems to be even genetically related to how you regulate serotonin. So what these medications do is essentially shut off the little vacuums in the sending neuron that would suck back up the serotonin maybe too quickly and allow the serotonin to stay in the synapse longer, which allows the neuron to the next neuron to activate when it might not have. It can stimulate that BDNF and also neurogenesis in the hippocampus. So that's what we want. We also know there are some blood flow and metabolic abnormalities as well. So in the dorsolateral and medial prefrontal regions, this is related to those memory and attention issues you'll see. These are so profound in some folks with depression that it's sometimes been referred to as pseudo dementia. It's like they're experiencing something like Alzheimer's. And so if you have an older adult who's presenting with memory and attention problems, you got to really screen them to make sure it's not just depression, right? I don't want to say just depression, right? Because depression is profoundly affecting your life. But you don't want to start treating them for dementia when that's not what not what they have. We see increased activity in the orbital region. We think that this is an attempt to like break that cycle, but of course it can't, right? The amygdala, so that HPA axis, and then the medial thalamus as well. The sleep cycle can be off due to your serotonin levels. And in fact, this is one of the reasons why people experience depression sometimes through seasonal patterns, right? Seasonal affective disorder is just a subset of depression. And when the light changes, and especially if you live in a place there, like it's dark a lot of the year near the Arctic Circle, right? Folks can really struggle. And so this is why one of the best ways to treat seasonal depression is there's a special type of light you can get that simulates sunlight. And when you use that, it actually sort of helps you reactivate your normal sleep cycle. Actually, really interestingly, when I had postpartum depression and I talked to a volunteer from Postpartum Virginia, the first thing she said to me was, how much sleep are you getting? You need to be getting at least 4 to 5 hours of continuous sleep per night. And as soon as I did that, it was like night and day. I mean, obviously I still had to go through therapy and get medication, but just getting that sleep helps to start regulating things, helps you to focus, helps you to be able to think more clearly. We know that if you have issues in your thyroid, that can mimic depression. So particularly if you have a client who has a family history of thyroid issues, you want to make sure that they're getting a full medical workup before you're just assuming it's only psychological, right? So we want to make sure that we're taking those things. So in addition to serotonin, dopamine and norepinephrine are also implicated in mood disorders. And as I mentioned, there's a gene called the 5-HTT gene. 5-HT is the chemical symbol for serotonin. And so it does seem to affect that the most. I mentioned the circadian stuff already as well. And in terms of bipolar disorder is more rare than what is sometimes referred to as unipolar depression. It seems like there are actually some anatomical differences here. So there's less gray matter in the temporal lobe and cerebellum. And the more episodes you have, the less gray matter you have, whether they're depressive or manic episodes. There's also this sensitization model. We know that people with bipolar disorders are sensitive to stress and drugs. We know that episodes of the mood disorder change the brain. We just saw an example of it right higher on this slide. So it seems like individuals who are genetically predisposed to have bipolar disorder may be more sensitive to stress and drugs, all right? And there seems to be maybe a link between psychomotor stimulants and mania in particular. So people with bipolar disorder are at high risk for drug abuse and may be especially sensitive to their effects. Mania may reflect an overactivity of norepinephrine in particular, and an underactivity in serotonin. So what they think is that people with bipolar disorder always have low serotonin, but when they're in the depressive episodes, they also have low norepinephrine. And when they're in the manic episode, they have high norepinephrine. So baseline of low serotonin, sometimes low norepinephrine, sometimes high norepinephrine. Sorry, just sort of jumping ahead here. That's that sensitization model I just covered over. It seems like there might be some metabolic issues as well. Oh, cerebral vascular disease. So this is really interesting. So people that have vascular dementias, for example, will often experience psychological symptoms. So I had a client, my placement year, my 4th year of grad school, who I thought she was bipolar at first. There just was like a bipolar vibe about her. And she talked about seeing things that weren't there. In particular, she like saw bugs all over her house, she thought. And at first I was just like, this is a woman who doesn't seem like she has a lot of income. Maybe she's living in a not great apartment complex, right? And so then she's like, I'll bring you some. Let's see the bugs. And so she brought me a little Ziploc baggie, and it was just like bird seed and lint from the floor and things like that. And so I tried to like address that with her, but to her, like even when she gave me the bag, she was like, careful so they don't get out. It just like to her, that's what it was. That was the bugs. And I was talking to our neuropsychologist over there, just like in passing, and I was like, oh, I have this really interesting case. And she was like, I was describing some of her symptoms, and she was like, does she carry around a little baggie of bugs, quote unquote? And I was like, yes. And I was like, is this a thing? She's like, yeah, that's a thing. That's vascular dementia. So you just like different, there's also in Lewy body dementia, people will sometimes have hallucinations, but they're specifically comforting hallucinations. Like they'll see people or pets who have passed on. And the really interesting thing is, like in schizophrenia, people sometimes, but don't always have awareness that their hallucinations are not real. In Lewy body dementia, they're aware of it. They know that this is not real, but they don't want to tell people because they don't want people to try to take away this comforting hallucination. So as you can see, related to strokes, we also see people experience depression and anxiety. And it can be like pathological affect as well. And so what we can go into next is what is generalized anxiety disorder, since that is common. This is just being anxious about anything and everything. It's like a free-floating anxiety. There's not one particular thing that'll set it off. It's like you're always worrying. If a patient told me I've always been a worrier on intake, I knew to screen for GAD. Doesn't mean they have it, but it certainly means I should screen for it, right? And so they get restlessness, feel like they're keyed up on edge. They're really easily fatigued because they're always anxious about things. They'll get muscle tension and muscle soreness from always being on edge. Irritability, sleep disturbance. Worry is the primary feature. And what we see is that there does seem to be a genetic component, in addition to some people experience it post-stroke. In general, with GAD, blood relatives are more likely to have it. So about 15% of blood relatives of someone with GAD will have GAD, whereas the general population at 6%. And it seems like there are certain receptors in the brain, in particular related to GABA, that are implicated here as well. In terms of treatment for something like a GAD, the first line of treatment back in the day were the benzodiazepines. Sometimes these are still used today. But these are essentially the medical alternatives that were described in the video about lobotomies. And so for folks who took these, sometimes they made them very compliant, very chill. There were also, I believe the medication they mentioned specifically in the video was an antipsychotic that had similar properties. And some of the antipsychotics had really bad side effects, including something called tardive dyskinesia, where they like lick their lips all the time and have weird movements in their trunk and face. But yeah, so benzos are things like Valium, Xanax, Ativan, Trenzine. It was interesting, they talked about in that video doing the lobotomies on board housewives or depressed housewives, because Valium in particular was often called mother's little helper in the 50s and 60s. So what happened historically is that during World War II, women were encouraged to go into the workplace, right? Men were away, we need people to man the factories, we'll man the factories, I don't know. And so they encouraged these folks to go into the workplace. And then when the men came back, they told them it was their patriotic duty to step out of the workplace. Some women that had been fulfilled by these jobs, some women that were college educated, were now told you've just got to be like a stay-at-home mom and wife. And so a lot of women struggled with this. And rather than sort of figuring out that this was a societal issue, they just started giving them big doses of anti-anxiety medications, or apparently in some cases they lobotomized them. Let's see, I do have a few videos related to some of the other disorders as well. So let's see, here's one about bipolar disorder. So this is someone who is actually living with bipolar.
There is still a stigma about mental illness. It is something that many of us are still uncomfortable talking about. But the fact of the matter is, it is more common than you think. There are millions of people who are living with and are struggling with some form of mental health issue every day. As we continue our look at mental health leading up to this summer's Courtnall Classic fundraiser, A News reporter Louise Hartland introduces us tonight to a woman who is living with bipolar disorder.
Christine McKinnon is putting the finishing touches on a work of art. But for the 45-year-old, this is also a form of therapy.
Kind of a chameleon of a disease because it presents quite differently in different people. And even from episode to episode, from mood to mood, you can get quite a bit of a difference.
12 years ago, after witnessing Christine go through a series of severe highs and lows, a friend told her it was time to get some help. Days later, Christine was diagnosed bipolar.
Bipolar or manic depressive illness is a medical condition giving people extreme mood swings. It affects more than 2% of the world's population, changing the way they think, behave, and function.
It was a relief for me when I found out that I had a name to what was wrong with me.
Christine was very depressed, at times thinking about suicide and hallucinating.
People often think the highs are exuberant and...
So an important point with this is that for some people who have bipolar disorder or even depression, when they experience those mood episodes, they also experience psychotic symptoms. So for example, I had a client who only when she was depressed would hear voices telling her to harm herself, like stick your arm in the oven, things along those. She didn't listen because she recognized that they were voices, but it's obviously very disturbing to her, right? Whereas when she was in a manic episode or not experiencing a mood episode, she didn't experience any psychotic symptoms.
Fun and high, and they actually can get quite debilitating.
For Christine, help came in the form of people such as Daphne Dobko-Walsh.
We try and teach them how to be independent and deal with their own illness.
As a community psychiatric nurse, Daphne visits people suffering with mood disorders. She assesses their health needs and develops plans to help them manage and recover.
The importance of having programs for people who are sick like this is no different than any other treatment that you would have for cancer or for diabetes. The more educated and aware that people are of what is happening to them, the better the outcome.
That's why she feels erasing the stigma around mental illness is a crucial step in helping people come forward.
Willingness is huge, having insight to know that there's a disease happening there, and also to have resources, to have the ability to connect with psychiatrists and or GPs and case managers or other community resources is so important. It's so pivotal in their wellness, their journey on their wellness.
With the love of her husband, friends, and family, willingness came easy for Christine. Now she's dealing with her illness with counseling, support groups, self-help, and medication.
And I would take about 300 to 400 pills a month. That's what these packages of drugs are.
Right. But all of the pills can't erase the shame Christine sometimes feels about.
So the reason she's taking so many is that oftentimes especially when you have something like bipolar disorder, one medication's not going to do it, right? You often need a combination of various things you need to take. And in fact, some medications are specifically meant to sort of augment other medications. So like Abilify is meant to be used in conjunction with an antidepressant to help with bipolar disorder.
About her disorder.
Here I am doing an interview and I'm terrified that half my neighborhood's going to find out I have bipolar disorder. Lots of people wouldn't know, even to know me, that I have a problem because I stay on my medication and I stay getting help and getting therapy. So.
And that's how Christine hopes things will remain as she stays in control of her life.
Louise Hartland joins us now with more. Louise, it's so important just to talk about it. If people are interested in this and would like to find out more about bipolar, where can they go?
Hudson, Christine and Daphne will both be on CFAX 1070 tomorrow morning at 11. They will share more stories about living and dealing with the symptoms of bipolar disorder. The Cordnell Celebrity Classic is back July 22nd to 24th, raising money to help people living with mental illness and erasing the stigma attached to it. For more information, visit the website CortnellClassic.org. Hudson.
All right, Louise Hartland, thank you.
All righty. Okay, there we go. For a minute, it just wouldn't exit full screen. I'm not sure why. I've ever called this depression videos very dry, so I'm not going to share that one. But one of the things she talked about was talk therapy. So I want to show this because some people, particularly if they're coming at it more from like a neurology or neuropsychology aspect, will say things like, why are you doing talk therapy? Just take medications. You don't need to do talk therapy. And it is not a waste of time.
This is how she started losing weight.
My name is Debbie, and with Noom, I've lost 100.
I get it. You don't want to sit and talk about your fears and worries to a stranger for weeks, and on top of that, paying a large amount of money in the process. After all, it is just talking, and you have some biochemical alteration in your brain that needs to be addressed, well, biochemically. However, just as it does not make sense to ask, do drugs work? It is important to note that not all therapies are created equally. We can say that different talking therapies work for different conditions, and cognitive behavioral therapy, or CBT, is one of the most scientifically studied talking therapies. It can be helpful to people suffering from mood disorders or schizophrenia, for instance, by helping.
So the schizophrenia research is really interesting because it had kind of been done for years, and then when the founder of cognitive therapy, Aaron Beck, was in his 90s, because the man didn't know how to retire, he got really interested in research on schizophrenia and really helped to advance the science of using this therapy with folks on schizophrenia. He died, I want to say, when he was 100 or 101, and obviously contributed quite a bit to the field.
Them to identify abnormal beliefs and thoughts with the goal of replacing them with healthier ones. For people with schizophrenia, the therapy involves learning to think differently about unusual experiences, such as distressing beliefs that other people represent a threat. CBT also involves developing strategies to reduce stress and improve well-being. But this is not merely advice giving, because CBT can change the structure and function of the brain. For example, when you see a face, the brain fusiform gyres send this information to the amygdala, which plays a central role in the perception and regulation of emotions, such as fear and anger. With this information, the amygdala interprets the facial expression to determine which emotion the person is displaying. Then, it sends this information to the prefrontal cortex, where you will have the conscious awareness of whether someone is happy or mad at you, and decide how to behave accordingly. The brains of people with schizophrenia show alterations in the circuitry, which may contribute to delusional beliefs, such as that someone is plotting against them. Remarkably, after weeks of CBT, patients with schizophrenia became better at discriminating the emotions from faces. In addition, CBT improved the connectivity between the amygdala and the prefrontal cortex while participants were shown faces. And the more this connectivity was enhanced, the more the participants stated that their symptoms have improved. CBT can be effective even when delivered via the internet. For example, people suffering from social anxiety disorder have excessive fear during everyday social interactions. A study from Sweden found that the more patients with social anxiety disorder fear public speaking, the greater the volume of their amygdala. But after undergoing internet-delivered CBT for 9 weeks, their amygdala shrunk, which also correlated with the degree of improvement in the fear of public speaking. This study also revealed that when these patients were criticized directly, their amygdala fired up intensely, more than the amygdala of people without the disorder. But after the therapy, this activity decreased to normal levels. Many other studies have shown that CBT can change the brain, and understanding what kind of change is necessary for clinical improvements following therapy is essential. Soon, neuroscience-informed psychotherapy promises to personalize treatment so that people can be prescribed specific therapies depending on, for example, the size of their amygdala. But in the meantime, it is remarkable that talking therapy with a professional can significantly change the brain for the better, even when delivered online.
So I wanted to show that because it's just so cool how they're finding that therapies, and not just CBT, just CBT is one of the most studied therapies, can actually change your brain. And what's really interesting about they were talking at the end, I haven't seen the like brain-based individualized therapy yet, but I have a colleague at University of Louisville who actually is doing individualized therapies based on a person's own data. So she'll have people fill out diaries for a week or two, take that data, actually figure out what the core components of their particular eating disorder is based on the data that person has shared, and they administer therapy targeting those components. It's quicker, it's more targeted, and it works just as well as doing the entire therapy. So you're going to save time and money and get something that's directly going to impact that person. All right, I'm going to stop a little early today because I do have a couple things that got thrown on my schedule at 2:30. So next week we're going to cover learning disabilities and sort of do a review of assessment.
Dr. Myers?
Yeah.
Hi, I'm like coming into class. I just wanted to make sure that you knew that. that I was
Yeah.
coming in person.
How far out are you?
Oh, I'm just like on campus.
Okay, cool.
But I was running behind at work, so I was like, oh, it's better for me to just be on Zoom instead
Sure,
of
yeah.
late.
Come on over. I'll meet you and sign your forms, and then I gotta run home. So
Okay, on my
sounds
way.
good. See you in a few.
Bye.